Welcome to End of Life University on YouTube. Today I'm sharing with you a conversation I had with Dr. Bob Uslander. He was a past guest on this podcast. And today we're talking about his organization, Empowered Endings, that he started with his wife, Elizabeth. It is a unique palliative and end of life care model addressing the physical, emotional, intellectual, and spiritual needs of patients and families. And we talk all about what they're offering through Empowered Endings. And I think it's really an innovative model, and it really does show us the way forward and where we need to be going with end of life care. So I hope you enjoy the conversation. If you haven't already, make sure you subscribe to this channel down below, and also subscribe and leave a rating and review for the podcast wherever you happen to listen. If you're so inclined, you can go to eoluniversity.com/support, and you'll find 3 different ways you can make a small financial contribution to help keep the podcast on the air. So we'll move on now with my conversation with Dr. Bob. Today, I'm so happy to welcome back my previous guest, Dr. Bob Uslander. I think it's been several years since we
In a bit.
talked on the podcast, but Dr. Bob and his wife Elizabeth, who wasn't able to join us today, are the co-founders of Empowered Endings, a unique palliative and end-of-life care model addressing the physical, emotional, intellectual, and spiritual needs of patients and families. Dr. Bob received his medical degree from the UCLA School of Medicine and was inducted into the AOA Medical Honor Society. And you can learn more about Empowered Endings at the website, which is empoweredendings.com. So, Dr. Bob, thank you for coming back and joining me once again. I'm excited to
You're
talk to you.
welcome, Dr. Karen.
um, yeah, maybe because it's been a long time since we had a conversation, you could just share a bit about your journey and how you ended up in hospice and palliative care as a physician, so our listeners can know you better.
Sounds good. Um, I originally I'm come from the Midwest. I grew up in Chicago, went to college in the Midwest, um, found my way to Southern California for medical school, and I felt very blessed to be accepted to UCLA and had a wonderful time through medical school. In the 80s, I ended up going back to Chicago for training in emergency medicine. And I was an emergency physician for ultimately for 25 years. I practiced medicine in Chicago at Cook County Hospital and other hospitals in Chicago. I moved to Guam for a short period of time where I got to help build an emergency medicine program on Guam. And then I found myself in a small town in Northern California near Yosemite, working as an emergency physician with a group there, which was wonderful. Loved, being up in kind of in the foothills of the Sierras, access to snowboarding and lakes, and it was just a very beautiful spot. Um, I moved to San Diego in 2011, kind of following a desire to transition from the career that I had been on to something different, something that I felt was going to be more meaningful, more opportunity to have more of an impact. And a lot of that's kind of came about from an experience I had in 2001 when a good friend of mine died from melanoma.
Mm.
And Darren was just a fun-loving guy. He had 3 little kids that were below the age of 6, diagnosed with melanoma that ended up spreading. And despite treatment, it was clear that his life was coming to an end. It was very aggressive. And I helped take care of Darren just as a friend who was also a doctor. He was a young guy, he didn't have a doctor aside from the oncologist who treated him, the best they could. And then when it was clear that this treatment was no longer effective, um, he was, told to go home and make his peace. And so I brought in the hospice team that was local in that community. And I had never been part of a hospice experience before. I had only seen people die in the hospital and in emergency rooms in the hospitals. People don't die gently. They don't it's pretty traumatic for the most part. And so I was able to help um, create this really beautiful end of life journey for my friend Darren with his beautiful family and his wife Rhonda and good friends. And it was something that really sort of transformed my understanding of what's possible at the end of life. I was with him when he took his last breaths and helped make him much more comfortable in that last phase. And then he died on September 14th, 2001, 3 days after 9/11. And the whole experience around that was just mystical and um, kind of it was very powerful, and that stayed with me. That experience stayed with me, and a short while later, a few months later, I started a house call practice for homebound seniors, and I got to help some people through their hospice experience. And then I started a home care company for people who needed more support, and I just kept working like in that realm of working with seniors and seeing where the gaps were and trying to fill those gaps. And then I moved to San Diego, and I had a few more experiences that were just kind of drew me. It made it clear that my calling was working with people at end of life. And I found through some random type encounters, I met a hospice and palliative care nurse who introduced me to the people who owned the company, and so I started doing palliative care, um, and I became the director of a palliative care program. And I really didn't even know what palliative care was
Hmm.
up until, this is 2013. So palliative care was still pretty new. Um, Worked in that realm, in that setting, and going into people's homes and doing traditional palliative care and hospice care for a couple of years. And it was really discouraging to me how many gaps still existed, even though the care was better and it was more aligned, towards patients' needs. They still had so many gaps that people couldn't, were experiencing. And so I decided, and both of my parents kind of went through an end of life journey that I helped them through. And I just kept learning more and more about what people needed. And I found myself really driven to filling those gaps. And so I started my own practice kind of outside of the insurance model to be more support, to bring like a holistic approach with doctors and social workers and nurses and music therapists and acupuncturists. So not trying initially I was trying to like create a better model of hospice
Hmm.
for people who were struggling. And it didn't require that they had a 6 month life expectancy. It didn't require that they be, that close to dying. We could care for people wherever they were along the spectrum. Um, and then after a few, and then my wife Elizabeth became part of the practice, and we really together kind of re-envisioned what was possible and what we really wanted to be doing, and together we built Empowered Endings, which is kind of the culmination of many years of work from both of us as individuals and then as partners. And Empowered Endings is a medical practice. So we have a medical practice where we do care for people in San Diego and throughout Southern California for complex and terminal illnesses. And we also built the Empowered Endings Institute, which is an educational platform, and where we're helping to teach people in healthcare and also in the community optimal end of life care, and sort of helping people see the model that we feel works so beautifully, which is doctors and doulas working in partnership together to provide care to patients and families. And then we have a foundation, the Empowered Endings Foundation, which is helping to provide financial support and some other kind of free resources for people who are going through the end of life journey. So, I mean, it's been an amazing journey, and it's sort of now just sort of coming out to really become what we've envisioned and hoped for.
It's so good to hear all of this because I think when we spoke the first time, having an institute and a foundation, those were dreams that you were hoping for in the future. And so I love seeing that they've materialized now and that you've actually gotten to this place. It,
It's incredible. Elizabeth has been, so incredibly committed, and she's really the backbone of building putting the beautiful website together, and the all the content that's being curated and collected, and the resource library that's coming out. So it's been a real um, wonderful partnership.
and Elizabeth, we should mention, is a social worker, right? She has an
Yes.
MSW.
She's a social worker and a spiritual counselor. So she has master's degrees in both social work and seminary. And she's the intersection of those two really is deeply rooted. End of life care was a place where those came together beautifully,
Mhm.
and so she's really worked with clients and helping to transform the experience, helping families find a way through it with more grace and ease. And so now she's really we're building the model to provide the kind of support that we found is so valuable, especially for families. We'll talk more about some of the gaps that we've identified and are trying to fill. One of the biggest ones that we've encountered, I know that you're aware of this as well, is the families of people who are, struggling with complex and terminal illnesses just don't have support.
Yeah, exactly. They're having to provide 24/7 caregiving for a loved one that they've never been trained for and aren't prepared for, even while they're dealing with their own shock and grief about their loved one's illness. And there's very little support and help for that.
And it becomes overwhelming, and it becomes traumatizing. And it doesn't take a lot to be there to show up for people, to provide guidance and advocacy, and that's where the end of life doulas become such a powerful piece of this village, members of the village, where they can really walk beside people. They're not telling them what to do. They're not even necessarily providing clinical care. They're a comforting, confident presence and advocate, um, that is really a valuable. It's almost like, how could we not have known that that was important? I mean, this is the stuff that people had before. The doctors and the midwives would help people through these really challenging journeys, and they would support people in their homes and be there. And the healthcare system has become so siloed. And one of the things that that we are trying to help people understand is hospice care, which is really the only service that is now provided and available and paid for people who are at the end of their life, is wonderful. And there's a lot of great people providing hospice care, and they fill in a really important need, but it's often not enough, and not many people understand that. And so everybody ends up struggling.
Mhm. It's so true, and it's why we do have people to tell stories of not having a very positive experience on hospice because they just didn't get the kind of support they could have used.
Yeah. Yeah, and we also hear stories about people who had a beautiful experience on hospice. We want to celebrate those as well and honor the amazing work that's being done. And let's be realistic. Hospice sends nurses out, once a week, maybe a couple times a week if really necessary. They have, social workers and chaplains who will, meet with patients typically monthly. The people that the patients typically develop the closest connection with are the health aides, who come out and actually touch them and help them and bathe them and support them a couple times a week. But then when they're not there, it's really the families that are left to do the work, and they're not prepared for it. They're not trained for it, and what they should be able to be as loving family members, and and not have to be figuring out all the all the details and doing it on their own.
So tell me what the patient experience might be like for someone who utilizes empowered endings. If you could, would they also have hospice care, but your services are in addition to that?
There's a wide range. So we care for people. I mean, we care for people who are at home with dementia or in facilities and are just wanting a better level of support, and the families want somebody who they know that they can reach out to in a moment's notice, and they'll get a response, and there's a team of people who are going to show up. We take care of people who are just more frail and they're needing additional support. I got a call yesterday from a woman who is a ER nurse in Los Angeles, whose father lives in an assisted living facility in San Diego. And he was in the hospital recently and then sent home, and they want someone who's going to be able to give them, kind of fill in almost like a family member, like, to go in and check on him and visit him on a routine basis and be available if something was to change. So he doesn't have to necessarily go back to the hospital,
Hmm.
but he's not ready for hospice. He doesn't need that level of support yet. And then we have people who are in the hospital, and they've been in the hospital 3 times in the last 6 months, and they're looking to not go back to the hospital, but they need better care and support and management. Also may not be ready for hospice, but so we help to provide a team that will transition them home and create a safe home environment and help them find the right caregivers and the right therapists, and stay very closely connected. And then we have people who are truly dying and they are under hospice care, but they want more. They want to have like a personal experience. The And then we have people who want to go through the medical aid and dying process. And we, over the past 8 years since the law became effective in California, we've been very active in helping to develop best practices for medical aid and dying, and then supporting patients and families, and offering bereavement support groups and preparation groups, and really doing that kind of support in a way that truly honors the needs of the patients, the families, and making sure that everybody is able to approach the end of life journey in however it's unfolding, with the knowledge, understanding their options, and having access to the best quality of life enhancing service.
Hmm. I,
So there's lots of different, types of
yeah.
services. We also do a lot of grief counseling. People come to us looking for support as they're anticipating the loss of a loved one or after somebody dies. We do a lot of grief counseling, and we also work and bring private nurses into people's homes when they need that level of support. So
Hmm.
lots of the gaps that we've identified over the years that have really, by filling those gaps, it's made a huge impact on people's lives. And so we're trying to kind of hone in and focus on doing that over and over again.
I love that you've created a model that's flexible, which means you're able to fill in the gaps. And whereas hospice, because of the regulations, um, and the kind of the standardization of care that hospice provides lacks some of that, and there are gaps around it because people don't know, but there are a lot of people who really could use extra help, but they get turned away from hospice because they're not certifiable in terms of their
Right,
prognosis.
right.
And so those people still need help, but they're out there with nothing because they don't qualify for hospice.
And palliative care, the emergence of palliative care, the palliative care model has helped. Um, Certainly, when people are in the hospital and they're dealing with complex issues, and the palliative care, the inpatient palliative care is very well developed, at least in our area, and I think more and more throughout the country. Um, and but the problem is, the palliative care people help to put together this plan that will support people optimally when they go home, but then it falls apart because there is no there's very little home-based effective palliative care. There are palliative care clinics where people can come in and meet with the doctors or nurse practitioners. There are some programs that will have providers coming out to the home, but there's the compensation model for that, the reimbursement model for that is lagging far behind. So it's not financially feasible for a company that's doing this through the insurance model to really be able to deliver the full experience of what people need. So they get what they get, and then if they're fortunate, they find a provider like us who can help fill those gaps. But as far as I know, we're the only practice that does this. So the vast majority of people don't have anything that's going to fill those gaps. And that's one of the things we're trying to change by helping to build, expand our model and teach people about the importance of, well, about the existence of the gaps and then the ways that they can be filled.
Yes. And tell us more about who's on your team. Like what types of practitioners do you work with to offer services? I know doulas, but
Yeah, we work with angels. I am so blessed. So it all starts with a phone call. You know, somebody they might come on our website and see the services that we provide and fill out a request to be contacted, or they might call. And Shauna is our patient care coordinator, who typically is the first point of contact, and she's remarkable and just a wealth of information and compassion. And so she'll find out what people are looking for, and sometimes it's pretty clear that we're exactly what they need, and sometimes it's pretty clear that we're not at all what they need. And often it's not, it's a possibility. And so she'll set up a consultation, a phone call, with me, um, to explore that. And in addition to me providing, the medical support and care, we have a couple of nurses that work with us, who also kind of call themselves doulas. They're nurses that have lots of experience in oncology and hospice, or different realms, but their focus is really to walk with people and guide the patients and families in a way that is truly, you know, supportive and empowering. We have grief counselors who have gone through grief coaching and doula training, and so come from non-clinical backgrounds, but have had a lot of life experience of supporting people through the end of life. We have licensed clinical social worker who helps to provide additional guidance and support and navigation. We also have access, and Elizabeth, my wife, is a spiritual counselor who is really sort of the spiritual heart of the practice, and helping to create the culture and infuse that, that real spiritual approach, not a religious approach, but a spiritual approach into all aspects of our care. And we have access to to nurses who can come and do shift work for people. Um, we have access to music there. We have music therapists on our team, and healing touch practitioners and acupuncturists and massage therapists. So so the experience for each individual patient and family is going to really depend on what they need. It starts out with a conversation about what their values are, what's most important to them, what their goals are, and then kind of coming together in sort of partnership to help find ways to fill those needs and achieve their goals.
so I love that you can truly customize the care based on each individual person's physical, emotional, spiritual needs at the time. And that's really wonderful.
And those needs evolve over time, right? The
Mhm.
needs somebody might, has now may change when they've decided to stop the chemotherapy and take a different approach, and so we can stay with them. And one of the things that I love about the model is that we have the grief counselors and doulas who engage with patients and families, as they're approaching the end of life, and then they can continue working with the family and staying connected after the person dies. So they already have this relationship and a full understanding of what the experience was, so that there isn't a need to sort of go through all of that and revisit, relive it all, and tell the tell the person about what they need. It's a relationship that is already developed, and our grief counselors kind of intuitively know what people need at that point.
Mm, that's such great continuity for the
Mhm.
family. And one thing I saw on your website that I really liked is that you talked about options for patients, but the first one is continue do everything possible. And I think that's the issue. That's another gap that exists in hospice, because for patients to go onto hospice, they have to stop curative care. And so many people are just not ready to do that. It's too big a leap, too big a step to take, and too frightening for them. And to be able to come into their lives when they still want to do everything possible and support them, you you can gradually help them move toward the time when they need to make a decision to stop the aggressive treatment. But hospice like turns all those people away. Oh no, you're not willing to stop. You can't be on hospice. And so again, those people don't get the extra support and the services that they might need that could really help them in that transition.
Yeah, one of the things that I love is when we get engaged with people and they're still working within the healthcare system to overcome whatever the challenge is, whether they're, treating a cancer or a neurologic condition, or they just had massive heart failure and they're on the transplant list, or there's a, we sometimes engage with people when things are really complicated, and they're, like I said, they're in the hospital and they need to be brought home, but they need services. They don't want to go to a nursing home. They want to be in their home, but so we can help coordinate a lot of the things that can be delivered at home: the nursing care, the doctor care, the lab draws, the x-rays, ultrasounds. There's a lot, the IV fluids, there's a lot that can be done. And sometimes those people get better and they say, thank you, adios. We'll call you in a few years if things change. We love when that happens. So it's interesting because we decided to call our collective empowered endings, but it's not just about the ending of the life. It's the ending of it could be the ending of uh, fear. It could be the ending of the complex nature of the overwhelm. Um, Most often, we're talking about the ending of a person's physical life, but sometimes the endings start years. Preparing for an empowered ending could could start years before. And another important part of our model is to do the planning with people. We get calls from people who they don't even have a serious illness. They just want to talk about how to make sure that when things do change, if they are diagnosed with something, or if their ability to remain independent, to care for themselves change, they want to know how to protect themselves from all of the craziness that they could be guided toward if they don't know how to protect themselves from it, and making sure that they have the conversations with their loved ones about what they want, don't want, how to address things if they're unable to make their wishes known, and then how to create the right documents that will protect them in a legal fashion. So the planning is another important part of the service that's being provided to
Yeah,
empower people.
and yeah, another, I mean, really vital piece of all of that. And you mentioned patients who choose medical aid in dying, and I'm just curious, in your experience over these 8 years, are there more and more people choosing it for themselves, and are there more medical providers who are opening up to the idea of supporting patients through medical aid in dying? Just, I mean, you're in California, so it's not true of the whole country, but what
Right.
you're
I can
seeing
speak
there.
to the California experience, and I can mostly speak to the Southern California experience, because
Yeah.
I am in contact with medical aid and dying providers, clinicians throughout the country. But my vast experience is here in California. The numbers are increasing. I think as awareness increases both among the population, general population, as well as among the medical community, more and more people are choosing medical aid in dying as a way to have a gentle, peaceful, dignified end of life. And and yes, there are more doctors who are willing to provide support for patients. I don't, I'm happy that patients are able to have more access. I'm also a bit concerned about people doing it, doctors supporting patients when they may not be able have the capacity or experience to do it in a way that really optimizes the experience for the patient and family.
Mm,
I know that there are times when people go through the process, get a prescription, and then are not given appropriate guidance as to, what to expect, how to discern, how to support the families. They're left to their own device, they're left on their own at the time that they take the medicine, which it can be really traumatizing for family members. Um, they might think that it's okay and they can handle it and no one's given them any reason to doubt it. But when they go through that experience, even though it's almost always a gentle and relatively peaceful experience, it can still be very, scary and stressful and result in traumatic experience, a stress response and potentially PTSD in some cases that is that can be avoided, that can wholly be avoided if it's being done properly. So I have some concerns about it just being kind of loosening there is no specific training required. There's no specific
mm,
certifications required for doctors to write prescriptions for people. So there's a difference between providing the service to a patient versus caring for the patient through the
mm,
process. And when the patient and the family are cared for appropriately, um, it's a very, very different experience. And
mm,
our foundation, the Empowered Endings Foundation, has um, a free bereavement support group for families, family members who supported loved ones through this process. And it's available to people anywhere in the country. It's on Zoom, and we find that when people come to this group because they've had difficult experiences, they're having trouble kind of navigating and coming to terms with things. It's almost always because they didn't get appropriate support going, leading up to and at the time of the event.
mm. That makes a lot of sense to me because I could imagine some family members might later have some doubt or guilt feelings and wonder if they did the right thing or made the right decision. And if they're being supported and guided all along in the process, you can address all their questions up front in advance so that they don't end up later looking
Right.
back and with a lot of angst about what took place.
Yeah, for sure. And I think it's critically important to have somebody with the patient who knows what to expect and is able to explain to the family what to anticipate and to be there with them to kind of support and guide the process rather than leaving them on their own. A lot of times, people are on hospice, and many hospices say that they're supportive of patients going through medical aid and dying, but they don't they won't allow their staff to many times be present in the room when the patient takes the medication, which is not which is kind of not showing up fully for where the people need support. They certainly won't let their staff mix the medication, so the family members are required to do that, or the patient themselves, which also leaves. We had a case where there was a physician who supported his wife through the process, and he was very experienced. He'd been in medicine for 50 years, um, and at the and they didn't get any support at the time of the ingestion, so he mixed the medication. He gave it to her to take, and she took it by herself, which is the way legally needs to happen. but he prepared it and he put it in the cup, and after she drank it, like he thought to himself, I just killed my wife.
Oh, oh my gosh.
And he panicked, and and then he went into doctor mode, and he was like being very kind of clinically astute and kind of monitoring things, and he lost the opportunity to be present with her as the loving husband who he would have wanted to be. And he experienced quite a bit of um, emotional turmoil and psychic distress after the fact, and came to the group to get support, and he's done beautifully through that. But there's that can be avoided, and that's a big part of our mission, is to avoid the traumatic experiences that don't need to happen but so often do, that cause people to suffer for years or decades. And um, supporting the loved ones through these, however the end of life journey is unfolding, providing support for them is really a top priority.
Mm. I'm just so glad that we're talking about this because I do see some people for whom the idea of medical aid in dying almost seems like a panacea in a way, like, great, this is my ticket out. This will be wonderful. This is fantastic. But we need people to be fully educated about what it involves. And yet, and I know it can be beautiful, but to remember that a lot of support and guidance is needed during that process.
Yeah, there's no question about it. For some people, less is needed. There are some people who have been talking to their families for 30, 40 years, and they've known since the kids have known since they were sitting around the dinner table as children, that dad always said when he can't
Mhm.
watch football, and or whatever, he needs people to bathe him, and that he can't walk, he's not going to want to stick around. And they've been kind of preparing their family forever, and now when it comes to be that dad has metastatic pancreatic cancer, and he says, okay, well, now we're gonna see you're gonna see that I meant what I was saying. And the kids are like, okay, we get it, you've tried, and we understand. Those are beautiful when everyone is just so prepared, and it just makes so much sense. Those aren't the majority of cases. The majority of time, there's some real processing that needs to happen, and understanding. One of the things that I like to help families recognize is, although they might feel resistance to supporting a loved one and making this choice. It's hard for them to imagine, why can't mom, like, just hold on a little longer, and aren't we enough to keep her going, and the grandkids come and see her every so often, isn't it, like, why couldn't she just kind of bear with it for. And one of the things that we help them understand is, like, how to experience life through their loved one's eyes, what it might feel like to be in their body, and ultimately to help them see that their acceptance and allowing and support can be such an incredible gift.
Mm.
So the loved one who's no one wants, these people don't want to die. They don't want to leave. They just can't bear living in the way that they're living. And once they get to a point where it's clear that they've reached that threshold and the quality of their life is so dismal, that the only option that they can see that makes sense for them any longer is to go to sleep. And when we can help people see that giving that loved one the permission and support is such an incredible gift, so they can help resolve any conflict, and just allow for that final experience to be so beautiful and peaceful. That's
Mm.
a gift that they can, and when they make that sort of transition in their minds, they're thinking about that. It's beautiful to see that, because that's going to change how they experience this forever. So. That's
Yeah.
always achievable, but it often is, and it's really beautiful to witness that.
Yeah. Oh, it definitely is. And seeing what's possible that you created with the intention to make this a better experience for everyone involved. Um, it's really wonderful. I'm really so pleased just to hear about everything that you're offering through Empowered Endings. But I'm curious about the Institute and what you're offering in terms of training as well, if you'll tell us about that.
Yeah, so the institute is ready. It's getting we're kind of populating it all, and before we're putting it out there and offering the actual trainings. So we're hoping that by summer. We were hoping to get it all kind of launched by March, and then some, other, as often happens, things weren't quite. We had to focus other places to and take a little bit of the focus off of that. But one of the most important parts of the institute is building community. So pretty soon we will be opening up this really beautiful um, offering for people to join the community and have access to educational materials, uh, webinars, videos, um, a number of things that will help people to understand the empowered endings model, understand how to provide support that is really based on the principles that we've that we embody, and the gaps that we've identified and are trying to fill. It will be really designed for healthcare providers, people who are like in hospice already, nurses, social workers, chaplains, for nurses that are in the ICU or the ER or the palliative care. And we'll also have an offering for people who are in the lay community, who are potentially caregivers or approaching their own end of life journeys. So there will be the community, and then we'll be developing programs, both virtual and ultimately in person, um, and providing additional levels of kind of intimate connection and certifications. So it's hopefully people can go in and learn what's available currently on the website, and then things will be evolving over the next couple of months. So we would hope that people can sign up and receive our newsletters, which will be kind of keeping people informed about each step along the way.
Will you
So I'm
be
very
off?
excited about that.
Yeah, that's really exciting. Will you be offering any training for, say, for physicians to do medical aid in dying and engage with patients around that?
Yeah, so that could be a component of it. Where one of the other important focuses is helping to create additional practices, helping doctors and ideally end-of-life doulas develop partnerships and create similar models to our practice in their communities. So we would incorporate all of the end-of-life options that we help guide people through, which includes the do everything, the supporting them through the traditional hospice route, medical aid in dying in the states where that's legal, and voluntarily stopping eating and drinking, which is another really empowering and beautiful kind of more natural process that we help support people through. Um, so the answer is yes, we will be working on training for healthcare providers as well.
Because it's one thing that I think about a lot is with we keep hearing about the high incidence of burnout for healthcare providers. And for me, I think part of it, providers who are just working in traditional settings, it's that we were never taught to embrace death as part of life. And therefore, every patient that's moving toward death feels like a failure and a lost cause. And it's just so sad because if physicians only understood how to have in their mindset that all these patients will die someday and that's natural, and I'm just part of their journey, and I'm here to help them have as much wellness and peace in their lives as they can and as much quality as they can on their journey. And it's not a failure when they die. I just feel like, oh, our training is just so limited and it's missing these important pieces.
That was so beautifully said, Karen. I'm gonna go back and listen to that again because that was really beautiful and it really sums it up. Um, and not every physician is going to be open to engaging in this way. In fact, relatively few are, for lots of different reasons, and that's okay as long as there are some, as long as we can identify the ones who accept death as a natural part of the life cycle and aren't afraid of engaging in conversations that could be uncomfortable and and being of service. Our model, as I shared, is built on principles that Elizabeth and I have identified are like foremost, fundamental, foundational for us, and they follows the acronym choices, because
Mm.
big part of our focus is on giving people choices, and we have a book proposal that's being shown to publishers right now, and the book is called Permission to Choose. So choice is a big North Star for us, and choices stands for commitment, honesty, ownership, imagination, collaboration, empathy, and service.
Mm. I
And
really
those are
like
the
that.
pillars. We're fully committed, and we expect commitment from the partners and the people we work with, and with the patients and loved ones to partner with us in supporting them. Honesty is critical, transparency and not being honest to the when somebody says, I don't want to know how long I have to live, and you're not going to force them to listen to you, but honesty about what it is that is happening and what it is that we can provide or can't provide. Ownership, just personal responsibility for everybody who's part of this team, um, for owning their role and their um, potential shortcomings and limitations, as well as their gifts and humanity. Um, Imagination, got to think outside the box. That's a big part of the healthcare system's challenge, is people are not supported and encouraged, allowed to think outside the box in providing the care that people need. So creative approaches to issues and finding creative solutions is paramount. Collaboration, everybody plays a role. Everybody's an important part of this, and we bring in anybody who can really add value, and that the patients and families are open to, and it's not hierarchical. We like to think of our model as like King Arthur and the Knights of the Round Table, where there's a very um we're a village, and everybody shares in the kind of takes ownership of it, and it's not hierarchical. It's not like the doctors here and the nurses are here, and everybody's sort of working on the same level. Um, uh, Empathy kind of goes without saying. You have to be empathic to provide the kind of care that we do. And service, we come from a place of service. We just want to do a good job, and to commit ourselves, devote ourselves to something that's very meaningful, purposeful, and we want to work with people who feel the same way.
Mm.
So
I
that all feels really good.
Yeah, I love that. Yeah, I love those principles and the mnemonics. Perfect way to remember those. That's really beautiful. And so it makes sense to me. I see it all playing out in what you're creating here and what you're offering.
Yeah, it's a big vision. And what it comes down for me, what it comes down to is just putting all that in sort of in play when I'm in the presence of of my patients and families, and and giving other people one of the things that I'm really most excited about is being able to find healthcare providers that align with this, that they resonate with it, and building this this community, this tribe of people, and ultimately giving them opportunities, helping them take the opportunity, take the initiative to be able to start providing care in this way, so that they are no longer experiencing the soul sucking challenges that are inherent in the healthcare system. Not that every aspect of the system and every place that you would work is going to be like that, but there are so many people
Mhm.
who are experiencing that, and they're so disillusioned, and they're so kind of heartbroken that they're not able to do the work that they feel called to do, because the system is just not supportive of it. And if we can help people start working in a manner and um, practice that allows them to do it in a way that's more aligned, we're doing such a great service.
Mm. I really like that idea. For a long time, I've thought about how broken our system is, and trying to figure out what do we need to do to fix the system? How do we do it? And it's actually an impossible task in some ways. And what we really need to do is create better systems outside of our current healthcare system that will lead the way and kind of show us what is a better way of doing things and help us gradually dismantle what's not working and transition into what's better. But if we haven't established what's better yet, we can't take apart what we have or we'll have nothing. So I think I love what
Right.
you're
No, for
doing.
sure. Yeah, yeah, be
Yeah.
careful. Right. I kind of feel like it's interesting. I kind of feel like hospice started that way. Hospice was, it's outside of the standard, hospital system and model. And it was really more like taking care of people at home the way that it used to be before we had all the nursing homes and before we had all the high tech stuff to keep people alive longer. So, but over time, hospice has become such a business. And now there's so much competition. There's so many hospices that are popping up because it's can be lucrative. Um, Even the nonprofits are competing, having to compete to stay open, and they're competing for the same staff and the same patients. So it's a beautiful model in its core, but it's and as we said, there are times when people get perfectly good care and it's all they need, but it's just not always the case. One of the biggest gaps that we've identified, and we didn't touch on this yet, maybe a little bit, but like a lot of people don't know that when somebody gets admitted to hospice, and most of the time it's delivered at home, but when they get on hospice, they will never see a doctor again. Most hospices do not have doctors that actually see the patients, other than for maybe certifying them to say that they qualify, or to recertify them. But most of the time the care is being delivered by nurses, sometimes nurse practitioners. But doctors need to be part of the end of life process. We should not have been taken so far out of it. And that's a part of, I think, what we're trying to, you know, bring back, is the caring doctor who can be a part of the process, and engage with the patients, engage with the family, so that they feel like they're getting truly expert, optimal care. And the nurse can say the same thing as the doctor, but if a doctor says it, it often carries a lot more weight. But it has to be the right doctor. It can't just be any doctor, right?
Yeah,
You know?
exactly. Well, I witnessed that so many times, like how frightening it was for people who were coming on to hospice who knew, I mean, their treating doctor may have just said to them, I won't be seeing you again. You don't need to come back to this clinic again. And this is someone they may have been working with for years in intense treatment for their illness, fighting for their life. And now suddenly this person's gone from their life and they feel completely untethered. And
Right.
to come on hospice and think, there's no doctor that cares about me. And I really felt for me, my most valuable role was to simply come and say, I'm here. I'm part of this team, and you do have a doctor, and I can come anytime, and I'll come and visit you if you need me. So once again, it felt to them like they're connected. They have someone who's overseeing their care, and it's just so valuable. And doctors really are a vital part of that team, and shouldn't be left out.
Yeah, and it's just it's not universal that they are, but it's pretty common and it's rare. You're rare, right? In this and it's rare to have a hospice that understands and supports that because it's expensive, right? They only get a certain amount of money per patient, and it's expensive to have doctors out there seeing the patients, so they don't do it. Well, we believe that people should have the option, and that's why we want them to reach out to find us.
Mm,
And I think some people will probably be wondering how people pay for it and how the cost
mhm.
of our care. And it's unfortunate that the insurance system model doesn't cover this level of care. We would love for we always say we would love to be able to do this and never get paid for it, and because it's so important, and that's where we come from. But of course, we have to take care of our families and pay our employees and all that. So it's a private model. We don't bill insurance. We don't bill Medicare. So we have a fee that's really based on the complexity of the care and the amount of service that people need. And it ranges anywhere from a handful of hundreds of dollars a month to many thousands of dollars a month for care that's really complicated and requires a lot of visits and oversight. And I'm really pleased to say that we work on a sliding scale so that we take care of patients regardless of their ability to pay, because people who can pay the fees and do so willingly help to cover the costs so that other people can receive. Not every service that we offer can be delivered for free or at a really steep discount, but a lot of them can be. And we encourage people to reach out to us to explore what we can provide. And that's where the foundation also comes in, is it helps to provide financial support for some of the medications, for some of the other care that people might need, um, so that we're helping to. So this is the model that we're really hoping to build. Is it's sort of a benefactor beneficiary model where the people who are able to pay do so, and it allows for those who can't pay to receive more support than they might otherwise, and the foundation can come in and also help to provide some of the necessary resources.
Mm, I love that model, and I really think in terms of insurance, it's part of that broken healthcare system in a way. And I think it's really important actually. For a while, we have to circumvent it for now because our existing insurance products are not necessarily working for the good and the well-being of the people who pay for it, of the patients necessarily. So I think we need models like this that for now we can set insurance aside until we can make some changes and fix that system a little bit.
Yeah, I mean, we use whatever we can. We use whatever sort of insurance services, resources, products are available. We try to, we hospice is covered by insurance. We get people on home health and use the nursing and physical therapy and nutrition services. We'll when people get labs done or x-rays, we try to do as much of it as possible through their covered services. We're just providing that extra layer of support wherever it's needed. Sometimes we're the full support, sometimes we're just there to kind of add additional support where needed.
But
Yeah.
I'd like to think, I hope that this model could be replicated in other areas. Do you feel that?
Oh, for sure, for sure. That's an important part of the vision as well. I don't know that every community can. I think communities that have a certain amount of older folks who are established, who have some savings and equity in their homes, and this kind of service that we're providing is really what the rainy day fund is for. right? This is, and it doesn't, you don't have to be a multimillionaire or even a millionaire. You just have to have a bit of resources. It's interesting because most of the patients that we see are already receiving some type of support that's not covered by insurance. They have home care providers, nurses, other types of things that they're already needing to access. We end up being a smaller percentage of that expense, but often a very critical piece to help sort of weave things together for them. And I would like to think that this model can be replicated in, we're in San Diego, but I know, as far as California, Los Angeles and Palm Springs and Orange County and Santa Barbara and, the Bay Area. And I know that I'm hoping that there will be more empowered endings practices popping up in different places over the next few years.
Any chance you could be a mentor or coach for people who might wanna start something like that, who could to,
Y-
pick your
For sure.
brain and get ideas from
Sure.
you?
And I don't know that we're not quite at the point where we have the bandwidth to do that. That's part of what the institute will be developing and offering. Um, we've also established a management services organization that when the time is right, when we feel like we have the bandwidth, will the management services organization will help to um, support other, ideally doctors and doulas, in establishing partnerships that the MSO could help to, support,
Mm,
and mentorship um and supportive services would be a part of that.
mm. I really love that. I love that doctor doula partnership. Uh, I think that's a fabulous idea.
Yeah, that because I love working with our doulas. I mean, we're all in a sense doulas, right? We're all doing the work of doulas in a sense. Elizabeth was sort of what I consider the original doula, partnering with the doctor when we were working in partnership and practice. And now we have a number of people who consider themselves doulas, and they're nurse doulas or they're grief doulas or they're dementia doulas. But we really feel like that's one of the missing pieces of this puzzle that can help to expand the support for this incredibly um, quickly growing population of people who need help.
Mm,
I don't think that I think we're going to be um, really kind of caught with our pants down when as the baby boomers are starting to really need more support for their complex and terminal conditions, and it's happening in expanding numbers. So
mhm.
I
It's
think
so
I think
true.
finding people like doulas who are passionate about being of support and can really extend the healthcare, the clinical healthcare workers, I think that's going to be a really critical piece.
Yeah, definitely. Oh, well, I'm so excited to see what's coming and what else you bring with empowered endings, Dr.
Thank
Bob. And I just want to thank you so much for giving me your time to talk about
Wow.
this today.
I really appreciate our conversations because you're an important part of this. You're a leader, um you're a pioneer in this space, and clearly uh, the choices, principles you clearly embody. So I'm really happy to be collaborating with you in this way.
Yeah, thank you. Yep, we're on the same team for sure, and hopefully we'll have more ways to collaborate in the future.
Yeah, for sure. Thank you, Karen.
Thank you. I hope you enjoyed learning about empowered endings and this unique model that Dr. Bob has created in San Diego. And take a look at their website and maybe follow along in case you're interested in any of the trainings that they're going to be offering a little bit later this year. So I'll be back next week with another interview for you. Until then, take care and be well.